It says you're live. So we're on.
Hi, eGP learners. So Andy and I are joining you today in a slightly different method. So we're practicing social distancing. Andy's at his place and I'm at mine. So this may work, this may not work. Hopefully you can hear us all right. And if you can, let us know.
Yep.
But thank you for joining us for the eGPlearning Podblast. And we're going to give you our digital primary care update for today as we still go through our current coronavirus issues and UK lockdown as well. Andy, go for it.
Yeah, so, sorry, a bit loud perhaps. Yeah, exciting times. A lot seems to have happened since we were last talking. Things were just gearing up for coronavirus, and now we're perhaps in a bit of a calm before a coming storm. I know a lot of us in primary care have gone through a period, well, it feels like a long time, but it feels like we've gone in just a week or 10 days. We seem to have completely transformed our model of care. We're operating telephone first at my surgery. I know you're probably doing the same, Gandhi, at your place. And I've been really, really impressed by people at my practice, by colleagues across the city, across the country, by all sorts of technology firms and people working NHS staff who seem to have been able to bring online lots of new tools, lots of new information, get lots of content out there. I know Gandhi has been very, very active getting content out there to help the community transition to this new model of care with lots more remote consulting, including telephone and video. So I'm just really, really impressed with everybody and just sort of sat here knowing that perhaps there's a bit of a storm coming. We're going to get a lot more busy over the next few weeks. So I'm just sort of thinking about how we can cope and how perhaps technology can help us cope with that. How are you feeling about all this, Gandhi?
Yeah, and similarly, so obviously it feels like the world in general practice has significantly changed, and we're looking at a different beast that we had compared to a month or so ago. Like you said, loads of people are generating lots of content and stuff to try and help clinicians. And we're going to signpost to a couple right now, actually. I don't know if we can show you on the screen or not. Could we do that, Andy, do you think? Or is that going to make us fall down?
So I think I can just drag things across onto the screen, which will probably look a little bit amateurish, but we're all learning. That's just that.
So first one, I thought we could show it. So interestingly, just today, one of our colleagues, Dipesh Gopal, has created a really useful Medium article that I would highly recommend everyone have a look at. It just basically summarizes everything that you need to know as a clinician when it comes to coronavirus, and that's in terms of information, in terms of things that you need to look at. So Andy's putting our show notes up. I think I can see right now.
No, this is the article you're talking about, which is absolutely excellent. I noticed there's a lot of featured content produced by yourself, Gandhi, and I think that's excellent content that's well worth a look. So
okay,
it's a
so I saw your show notes. I didn't see. There we are. That's the article. I can see coming up now. There we go. And yeah, basically, it's in great sections. It talks about how coronavirus symptoms, assessing. It's got some of the stuff that I've created, so there's a little bit of decoration there, but really good quality information. And basically, if you are a clinician working with coronavirus, needing clinical kind of guidance and support tools, definitely check out this article. It takes about 20 minutes to read in total to get through everything. There is a lot of info there, but there's lots of resources as well, and it's really, really good summary. The other one I'd like to mention, if Andy can bring it up, is a group called Primary Care Pathways. So this is managed by a colleague of ours called Dustin Saint, who runs the Primary Care Pathways. People talk about how productive I've been with all this kind of stuff. I'll be honest, he makes me look like somebody sitting there twiddling his thumbs with the amount of content and stuff that he's been able to produce for us. And basically, it is the best dashboard of coronavirus information I've seen, because it just brings in everybody's stuff. So that is on, where are we? There is a short link for it. I'm just trying to look for
That's cool. It's on the screen, Gandhi. I think you've got a little bit of lag because you're watching the feed, aren't you? So you're just a few seconds behind what's appearing on the actual screen.
So there we are, Primary Care Pathways. It's just massive dashboard of information. Highly recommend any clinician have a look at that. There's just tons of information and loads of resources. And it links into other kind of stuff. So another colleague of ours called Jack Orr, he's been creating loads of tech stuff to try and help you get clinical systems onto computers and stuff. If you're struggling to do that with all the VPN access and all that kind of stuff, definitely recommend. All those resources are in that page and things. So yeah, effectively just wanted to look at those from a remote consultation point of view. Red Whale created a really useful basically webinar of how to do remote consultations. Again, slight declaration, I'm on that talking about how to do remote consultations with them, but we cover everything from telephone, video, and all the complexities that come with that. Similar, Amon's done some short videos, and if you wanted quicker updates and stuff, and yeah, loads of content going out there. But anyway, I know one of the things we wanted to talk about mainly today was obviously the flow of patients, wasn't it, Andy, in terms of what we're going to do and how we're going to manage them, because there's potentially a storm coming.
Yeah, I think so. I mean, I think everybody sort of acknowledges that we're perhaps still on the upwards curve of a surge of coronavirus cases, and a lot of that will hit primary care, and we're going to have to be smart about how we manage that. I think we've already done quite a lot in terms of transforming how we're operating to a telephone first service, and I think we're going to be needing to do more, I think, in the coming weeks to further transform the service so that we can deliver what's going to be needed to process what might be quite large numbers of patients who are concerned or potentially unwell who will be presenting to primary care. I know there's a few models that are being talked about and suggested, so we're beginning to hear a lot about hot hubs, cold hubs, and also about how people will be triaged both to those places and on the phone, and also to self-care at home, because the vast majority of people will have mild symptoms that will be suitable for self-care. So I think this model of a lot of triage work being done by GPs, as well as a lot of other people within the system, coupled with cold hubs, potentially seeing shielded and non-COVID cases, and then these hot hubs that are being talked about and are being set up in different locations around the country to process what might be quite high numbers of patients with potential COVID-19 infections. So to get the flow of those patients right, I think is going to be really tricky. But I think actually with the progress we've already made, and with the help of technology, particularly remote assessment over the telephone and video, I'm hoping that we'll be up to the challenge. What do you think, Andy?
And I think you're right. I think there's several things that need to be considered. So I know obviously a lot of our colleagues are going through the motions of creating effectively these hubs and these systems in their local areas. Obviously, me and you have been involved in these as clinical directors for our local area, and I guess we wanted to share some of our experience in terms of what this needs to potentially look like or how it may flow. I think the key thing is the first part of this is going to be the triage, isn't it, Andy? Because clearly you need a protocol of who gets seen where. But what needs to come with that is the triage aspect. And I know from my perspective, I think this is an area where GPs really need to consider their role in terms of what are they most effective at doing. You really do want your best triagers doing this to make sure that you get the safest flow of patients and also the safest impact for clinicians as well.
I think when you talk about triage, what I've always heard and always believed is actually it's most effective when the most senior, most effective person does the initial triage where that's at all possible. And I think actually the system might be in a reasonably good position for that, because what we have been doing is reducing the amount of routine work that we're doing and clearing our decks for the next few weeks. So actually I think there will be quite a large capacity for GPs who aren't necessarily working face-to-face in hot hubs, who are in their normal practices seeing essential work with cold patients. I think there ought to be quite a lot of spare capacity there to do a lot of effective telephone triage. So I think we're really fortunate in that, and I think that's probably why a lot of us have been asked to reduce the routine work so that resource is available.
And I think it's important to recognise as well, so the government's outlined that it's trying to bring back some of our colleagues that have left the profession, retired recently or left for other reasons, trying to bring them back. So we've got an additional workforce. I know they've commented it's something like 7,000 additional workforce potentially that's coming back. I know a lot of them are planned to be doing a lot of the triaging work, whether that's through 111 or through a different system to signpost patients to where they need to go when all these hubs are operational and into the local flow. And I guess my key message I would like to give to those people that are doing that, look at the information that's there to support you with doing remote working, because the challenge is some of those clinicians may not have done remote working, and what we don't really want is everybody comes down to a hub because those clinicians are feeling anxious about how to manage the clinical risk. There are really good supportive mechanisms to try and help people understand how to assess a patient effectively through a telephone or video consultation, which particularly with the coronavirus stuff, Tricia Greenhouse got some really amazing quality information in terms of evidence and assessment. People talk about things like the Roth score. People talk about other ways that you can use information through a remote consultation to help make a decision about, does this patient need admission, not admission management. Look at that information, because that's the thing that's going to limit how much of this works effectively. Because if everybody ends up going to a hub, the hubs are going to fall down.
Yeah,
that's the worry, and we can't have that happen, because otherwise we're going to see real problems in local areas.
Yeah, and Gandhi, I was going to add, I think it's really, really important that those of us who are designing how these hubs and how the systems will operate locally make sure that everybody is on the same page, probably using the same centrally or regionally produced or locally produced resources to triage effectively. Because what you don't want is those people doing the telephone triage, perhaps they're the retired GPs and nurses coming back operating within the 111 system, following a certain protocol that identifies who they think need to be triaged, and then when they arrive at hubs, people are saying, well, why is this person here? It doesn't match our local thing. So I think it's really, really important that everything is really, really joined up, and that everyone involved in what will be a whole system delivering care is on exactly the same page. So it might be helpful, I guess, to... are you looking at some comments coming through, Gandhi?
I am.
Because you're on your phone, aren't you? Looking at comments on the phone because of how the technology is today.
So shout out to obviously our live joiners. So we've got Roy, we've got Becca, and we've got Stefan, who've already commented on the chat. A really important one by Roy. Retired colleagues will be better dealing with non-COVID patients run by call by NHSE. They're effectively looking at re-triaging all of theirs potentially, which I think is the concern. That if we get the wrong flow of patients coming through, that the local hubs are really going to struggle. So I guess it's just that clear message to our colleagues that are supporting us. Please, if you're unsure about doing remote triage, are you the best person to be doing that? And if you're looking at creating your hub, it may be that what you need to have is your best triaging people, and you can identify that within practices and stuff, how they work and stuff, but they're the ones that need to be triaging, not necessarily always seeing patients face to face. I think there's going to be an element of both, but it's the focus of where is staff, where are your resources best placed to work, not just the case of everybody doing everything.
Yeah. So Gandhi, shall we break this down and perhaps look at how technology might be helpful at the different points? So triage initially.
Yeah. So I think triage. Obviously, I mean, we've covered quite a lot of this in our previous stuff. So I think it's important we don't go into too much depth, but simply look at the way that triage can help you. So in terms of consultations, whether that's by telephone or by video, what's the best route for dealing with a patient? Telephone's really good for a lot of it. I think a lot of the patients with minor symptoms you can manage quite effectively over the telephone. I think video adds the added element of being able to see the patient, and often for a clinician with good experience, that's all they need is just to eyeball the person, and that's enough. Sometimes you can see the level of discomfort they may be in, the level of breathlessness they may be in. You can ask them to show you how they're breathing and stuff, and it allows you to do things potentially like the Roth score and that kind of stuff a bit more effectively. Important to recognise the Roth score does have some elements in terms of validity in this situation, but it's just an additional tool is what I would say. It's not the default, this is your answer kind of
I've been finding the Roth score helpful. Something I've noticed with telephone, I've tried to do it a few times on telephone, and patients can find it really, really hard to understand what they're being asked. It's so much easier with video. The other thing I would talk about telephone versus video is the pattern I've dropped into now is I start everything on telephone because I find it quicker to consult on telephone. And if there's clearly no need to go any deeper, I don't go any deeper. Once you get people on video, or if you kind of start out with a video consultation, it can be long, and sometimes if it's not critical that you see that patient on video, it can be a longer consultation. So I find it really helpful to start telephone. If I think I need to see them, then I just escalate to video, and I use the Accurix tool and say, right, I'm going to send you a link. You can even stay on audio while I describe and get you into the video consultation, and I can troubleshoot for you. Let's get there. Then I can see them, do a Roth score, make a better assessment, drawing on the information I've already got from them on telephone, reach a conclusion quickly and move forwards. So we're not offering patient choice for video. It's a tool for the clinician to switch to if they feel that it's going to be helpful. So that's just my words on how we're using video.
Agreed, and that would be my suggestion of how you don't default to everything for video because it takes longer. Telephone is your priority if you need to upscale to video, and then clearly if you still feel that the patient needs to be seen after that point because the video hasn't worked, that's when you need to consider face-to-face. And actually, normally the outcome from video is either you're fine, you can stay at home and here's symptomatic management, you're not fine, you need to go to hospital, and then it's the middle category. It's the ones that, we kind of need to see you. They potentially are the ones that are going to end up at the hubs to be assessed. And obviously, then you need the protocol and the understanding of how that flow is going to work. And I guess it's worth talking about how that potentially may be experienced for patients and clinicians when they're working at the hubs.
Yeah, so Gandhi, I suppose once we get people down to the hub then, so we've triaged, they're coming to the hub. I mean, how these hubs don't necessarily exist yet, and they might they might take all sorts of different forms in different places, depending on the type of premises that's being used, the type of people that are there, the type of resources and technology that's available. How are you seeing a hub working in your area? What might your hub look like?
Well, as you said, different places are going to do different things, and it depends on the estates that they've got, and it also depends on the workforce that they've got. I think what's going to happen in the majority of these hubs are going to be by appointment only. They're not going to be walk-in centres. They're not going to be, like A&Es where you just turn up if you've got symptoms. The priority has to be triaged by the practices. If you are a COVID-likely patient or a person at risk of COVID, then that's when you're going to be seen at the hubs. There is the potential that a patient with absolutely no risk of COVID, as best as we can establish, may still be seen at practices because that's safer to do so. But we do know that the numbers are going to change in terms of background population risk, and we're seeing that already. And then effectively, there needs to be a flow of how this works for patients. So we have to factor in social distancing. So the fact that the people when they turn up, they have to be about 2 meters or so apart from everybody else, and that includes the staff. So it's going to be a very different experience, I think, for patients when they attend a hub compared to what they would get at the practice. It may even be as draconian as here's a line of tape, you follow the line of tape, here's an X, you stand on X while we assess you. The clinicians will be, using protective equipment, so, shield, masks, goggles, gowns, all that kind of stuff potentially. So it is going to be a different experience for patients to comprehend with. And, you won't be able to talk to other people in the waiting room because you're meant to be practicing social distancing. You're going to have to shout if you want to do that. And that's not really the kind of thing we want people to be doing. And potentially these people may be quite unwell, and there's going to be challenges. So I know one of the things we were talking about is, can people attend with patients when they come to a hub? And I think there's going to have to be a significant limit on that. It may only be, you can only bring one person with you maximum if you need them. So situations, parents-child, for example, clearly we need a guardian there, other kind of situations. So it's going to be a challenging experience, I think, for patients to understand, but that's where clear signage, clear instructions, potentially sending text messages to patients to say, this is your appointment time at this, it'll be stratified as well. I don't think it'll be necessarily appointment time, it'll be an appointment slot, a couple of hours slot that you have to go within this time frame to try and manage the flow. Because you can't have everybody turning up at the same time. Because if you've got 200 people turning up a building, how are you going to social distance 200 people?
Yeah, I think you're absolutely right, Gandhi. I think it's important to put in that work, and it may be what we're all doing in our heads this weekend, just thinking about what the patient sort of experience is, as in designing that patient experience, because you want to almost design and stage manage that experience so that people behave in the right way and they've built the right expectations, and that starts with the messaging at triage. When they arrive at the hub, the signage needs to be right. They need to know what is going to happen, what to expect. We've probably got the privilege of having a sports hall next to our medical facility in the hot hub that I'll be involved in. So we've got a good space for indoor queuing, at least, using the sports hall space. We are thinking about taping distances on the floor, potentially using that within clinic rooms or the clinical assessment areas, some of which could be within the sports hall. So because we're concerned about the level of PPE, whether we're going to have the PPE that we would want. Hopefully we will. But actually distance is going to be something that's quite useful to supplement that PPE. So if we can enforce that with tape on the floor in the clinic rooms. Okay, clinicians stand here. patient sit or stand here, this is 2 meters apart, 3 meters apart. That will supplement that distancing, and only approach to examine if necessary. We might be getting people to perhaps take their own SATs readings, things like that, and really minimise the actual contact, just to supplement the effectiveness of the PPE. I know you could potentially use technology to do that if it's absolutely necessary as well. You could be having conversations, on phones and using technology even within hubs. Not quite sure how practical that might be, but I think we need to be creative in designing these hubs and not just think about the clinical protocols, but think about the experience and flow to and from hubs.
Yeah. So interestingly, Roy's mentioned on the chat that they're going to let everybody wait in their cars and then call them in at the time they've got their appointment.
Great.
I think that works really well from a social distancing point of view. My only concern with that would be if you've got a hub that's unfortunately in an area where parking's a real problem, then you're potentially going to have issues. And obviously that's something that some places are really going to have to think about is, stuff they wouldn't really have to have thought about before, like parking, to this significant level. If you're bringing down a couple of 100 people a day, you're going to have to figure out how that's going to work. Interesting, you talked about using screens and stuff in consultations. We may see situations where patients are called into a room, asked to stand on a spot, and then literally the clinician walks in, examines them, and walks out. And that's a distinct possibility. I know there's some models where have talked about that. And then potentially the remainder of the consultation, the plan and everything is either done by that same person through a remote interface, like a screen or a tablet or something like that, or potentially even a different clinician, because they're just using the information that's been provided by the doctor that's or the nurse or whatever that's examined them. So it's supplementing that to try and reduce the contact time that's with patients. Because one of the things we know about the COVID virus is the viral load that impacts how and well you're potentially going to get. If you have repeated high exposure, that you're unfortunately more likely to have much more significant symptoms. And clearly from a healthcare worker perspective, our emphasis will also be to not only help our patients, but to try and make sure we've got the safety of our staff in play as best as we can.
Yeah, well, we can only be effective if we're at work, can't we? So
exactly.
People can't be getting sick and having to self-isolate themselves.
And I think that's probably a good point for us to talk about the PPE, isn't it, really, Andy?
Yeah, so something really... so I think up and down the country, some creative things have been happening with PPE, but I know here in Nottingham, Gandhi, so you started this, you identified that I think potentially in other parts of the country, people were beginning to 3D print face masks. I know that's something we've not been provided at our practice in our basic kit. I'm not sure if we're going to be provided some. And if I'm going to be seeing large numbers of patients coughing and spluttering, I'd really like some face protection. So pick that up there, Gandhi. So what happened next? So you were aware there were plans. What happened after that?
So I think it's important to recognise that obviously the government feels that a apron, gloves and surgical mask is enough for primary care clinicians and those out in the community to assess patients with coronavirus-based symptoms. That is the government's view, that's the Public Health England's view. I appreciate that many clinicians do not agree with that view, that they feel that puts them at an unsafe disadvantage and potentially higher risk of catching symptoms. So as a result of that, trying to get workforce to work in these higher risk areas is becoming a challenge. So I was really interested to see some work being done by one of our colleagues called Dave Trisker, who's basically put out a call to his local population to help 3D print visors. So, these aren't hazmat suits, these aren't absolute protection. These are just simply a plastic visor that covers the head area, because the head's the entry for the virus, effectively. It's the mouth, it's the nose, it's the eyes. And if you can reduce the spray, that's some benefit in terms of reducing the potential infection to the healthcare worker. And these can be 3D printed, because they're basically a headband, something to tie around the head, and a plastic visor. And we're seeing really amazing designs by our local communities there. So using some of that work, so there's a couple of people I'm going to mention here. So I mentioned Dave Trisker, who showed me how all this kind of information. But there's a national movement called 3D Crowd, I think it's .co.uk, that's trying to coordinate on a national basis printing of these visors for healthcare workers, and that's both primary and secondary care. Locally in Nottingham, really big shout out to TechNot and to Nottingham Hackathon, who have been supporting us trying to find ways of being able to do this for our local area in addition to the national stuff. And we're hopeful that we can be able to produce some visors fairly quickly for our workforce that's going to be additional PPE to what they're being provided through NHS England and through the Public Health England. Key point, it's additional, it's not in place of, because obviously our guidance is that this is what you should be using. And there may, unfortunately, there's an element of we're muddling through this, to be honest, because trying to produce, completely effective lab equipment style versions, that takes time, that takes money. Unfortunately, they're two things we're a little bit lacking on right now in terms of being able to do.
Yeah, I think part of this is, even if it's not, 100% as good as, a proven tested medical product, even if it's 70%, 60%, 50%, when you're seeing a lot of symptomatic patients, those imperfect numbers will offer some protection. I'm a firm believer in that. And also part of this is psychological as well. So, okay, the government says what they think is sufficient, and that might be the case, but I think we're going to have trouble convincing doctors and nurses to come and work in these hot hubs. Potentially, if we're not able to offer this additional protection, or at least offering this additional protection, will be helpful for getting volunteers to come and help. People do have some concern about their own health. They might have family members who are unwell. They don't want to contract the virus and pass it to them. So I think it's going to be helpful. So I'd like to thank you and the community for the work that you're doing, and that's really appreciated.
Massive shout out to our Nottingham-based tech community that are really just getting behind this. I appreciate some of them are really keen to do stuff, and we're in some ways even having to say calm down, because we just want to make sure we get it right as well. But at the same time, really big shout out to Nottingham Hackathon in particular. They've been really supportive, trying to get some of this stuff out for the area, and we're hopeful that we can get something out fairly quickly actually together, that will provide extra protection to our areas. And I know in other regions these kind of things are being done as well, so definitely plug into your local community, because they're there to help us. We're seeing that, and we're going to need their help.
And I think people want to do something to help as well, because people have down tools. They're not doing their normal jobs often or to the same extent. So it's just really helpful to give people the opportunity to help too. So Gandhi, people at your place stressed? I know we've got people beginning to feel stressed, and it's going to be a marathon rather than a sprint. And we might be about to start going up a big hill in terms of the amount and intensity of work we're doing. It's important that we look after our staff, that we look after ourselves, that we look after each other, and maybe tech can have a role in that. So any thoughts on that?
Yeah, I definitely agree with you. We know that this is not going to go away in a week or two. This is unfortunately going to be with us for a few weeks, potentially months, and we are unfortunately, like you said, heading up the big hill. I think key things, people are stressed, so it's remembering to recognise when you're getting towards that point that it's getting a bit much. I think tech can help, like you said, so various different things. I'm a big fan, as many of you know, an app called Sleepio. So it's created by a company called Big Health, and it's really good at helping to rationalise your sleep patterns and stuff, and make you get more effective sleep without having to resort to medications and stuff. And I've used it a few times when I've been struggling. And the company that owns that have basically made that and their anxiety management app, the Daylight app, basically free for everybody. So that's free for staff, that's free for patients as well. So this potentially is a tool you could signpost patients to if they're feeling anxious or worried, because let's be honest, everybody is to some degree. And yes, it may not be counselling face-to-face, but actually that's a real problem right now. But it's just an additional thing that can offer some support. And some people say, well, how can an app make me feel better? I'll be honest, try it. It's surprising how much difference these things can really make. Yes, they are not absolute perfect treatment for these situations in all situations, but I think they can really just help offer some opportunities. There's other apps out there, there's Headspace, there's Calm, that's got that kind of stuff. They're all really good as well. A lot of them are offering free access in the short term. But also there's this element of us working together, and I know you've done quite a few things like this in terms of things like obviously we're both big fans of Zoom, but there's other platforms as well.
Yeah, so I've noticed that, so there's been a big increase in WhatsApp activity, obviously, and a lot of that is work related and spreading a lot of the the positive information, the protocols, the good work that people are doing. But in some of the smaller WhatsApp groups I'm in, local medical community, practice WhatsApp, friends groups, there's been an increase in the kind of humorous traffic and people being supportive, reaching out to one another, posting videos of what they're doing at home. I mean, we're in the healthcare community, we're all pretty busy and more busy, but other people are having to kill time a little bit, and it's nice to see the humorous things that they're getting up to. So I think embracing technology, both to improve our working lives is great, but also to improve our downtime, given that we can't actually physically see people. The other thing, I'm having a Zoom happy hour tonight with friends, so I'm quite excited about that. We're doing a pub quiz. Each household is taking 10 questions in a topic area. We're doing history over here at my house. And I'm really looking forward to it. It'll be nice to connect with people because we've not seen people for a few weeks. So think about using tech creatively to support your downtime as well.
Definitely. I mean, I've been involved in my religious community in terms of setting up systems to try and help, the vulnerable people within that community, but also the community itself maintain its links. Because, all of a sudden we've lost our regular gatherings that we had. We can't meet physically face to face, and we can't do all of the religious stuff that we would do as a community. But how do we still support our community to be effective and support definitely the vulnerable parts of that, but also function to maintain our identities as well? And that's where things like technology can work. So we've got groups that are still learning information through, like you said, Zoom or other kind of platforms that are available, and just having that opportunity to do so, because what we can't forget is that the well-being of everybody. And I know there's quite a lot of opportunities to explore this for people, and I really recommend doing so.
Yeah, absolutely. And the other thing not to forget as well, so we, like many places, we said, right, those staff self-isolating but still working, we'll bring them in to a video conference with the COVID-19 briefings and the staff meetings in the mornings. And we did that, and then one day we forgot to invite James, who was working from home, and later on he was battering the door down on WhatsApp saying, "Oh, make sure you invite me tomorrow. Why didn't you invite me?" And actually, I think we didn't appreciate that. Actually, he did value that an awful lot, working from home, both just to see everyone, but also to just touch base about how he's operating, calibrate how he is working, his risk tolerance level in relation to cases, because we're all operating in a new way. And so we'd missed him out, but he obviously was finding that valuable. So remember your colleagues self-isolating but still working, and bring them into your briefings.
Yeah, and I guess another quick shout out to James. So he's created a really good video with the Nottingham Hub, Healthcare Hub, Training Hub, that's the one, that is quite a humorous take on how to work from home. I must admit, I really enjoyed watching it.
I had no idea his house was so messy.
Yeah.
To begin with.
So we're going to recommend you watch this just purely so you can see how messy James's house was.
And how long it took for him to tidy it up. Definitely have a look at. We'll put the link in the show notes once we finish recording and stuff. But definitely worth having a look. If you want some more details, I've also got an article that you guys can have a look at that looks at various different things when it comes to home working from a remote perspective, and also remembering not to feel guilty about it. I think that there's this other element of the workforce really struggling with that because they can't do what they normally do. They feel guilty about the fact they may not be on the front lines, or they may feel guilty about not being there for the rest of their staff, or even sometimes people blaming them for not being around. And it's important to remember we're in an urgent situation. We're being told we have to do this quite rightly to try and keep social distancing, to keep people safe and that kind of stuff. So remembering that we're in this together, and we're only going to get through it by supporting each other together. Yeah, that's a great message to almost end on. But a service status announcement for the Podblast in the weeks coming up. So Gandhi and I are quite deep in primary care networks and in potentially the hot hubs. We're not sure, but it's possible that they may even need to run 7 days a week at peak capacity. So output on the channel might be disrupted in an unpredictable way. So if we're not able to stick to the normal release schedules, please don't be too hard on us, and we'll return to normal service as quickly as we can.
Yeah, I think it's just a quick, and that's both for the Podblast and for the eGPlearning Tip Thursdays as well. Unfortunately, we would love to say that we commit to having tons of resources available for you guys, but the reality is our time is being massively taken over, and we're just anticipating that in the next month or so we may not be able to create as much content for you as we'd like to do and keep up with the updates. But what we can promise you is that as soon as we're able to, and if we are able to, we will get stuff to you guys, updates like this, information like this, and other kind of things as well. So also recent stuff, if you want to check it out, the MS Teams stuff that we've done in terms of how to use MS Teams, really recommend it. And a quick shout out on Monday. So I've had a really interesting chat with Jeeves Wijayasuriya, former chair of the Junior Doctors Committee. And we talk about specifically for trainees, basically what COVID means for you, because there's a big group of people that suddenly found out that their exams and everything have all been cancelled. And what does that mean? So yeah, that's coming out for you on Monday evening. So check out that if you're a trainee.
Excellent. I've just brought it up on camera just to show people the eGPlearning page on YouTube, and that there's loads of great resources out there. Pretty COVID dominated and video dominated at the moment, but that's the flavour of the day, isn't it? It's very important.
It is. Good. So as always, guys, thank you for joining us. We're going to sign off now and let you all get back to your comfortable weekends. Do look out for yourselves. I appreciate we are both notoriously bad at being busy, I think we're both having to recognise that we need to make sure we're also looking after ourselves and look out for your colleagues. Definitely stay safe, stay at home. If you are somebody watching this that's thinking going outside is a good idea, don't, please, simply don't be silly. And as always, if you want to follow our content or contact us, we're available on Twitter, Instagram, YouTube, LinkedIn, all those kind of platforms as usual. Podcast, if you are listening to this, we'll get it out for you shortly. Definitely subscribe and make sure you leave a review on iTunes. We love it when you do that. It really gives us a high. I've had some really nice comments over the past couple of weeks, and they have been very uplifting at challenging times, I must admit. And if you're watching on YouTube, definitely subscribe. Ring the bell, get notified of all of our content and stuff. And it's amazing that you're doing it. We are just shy of 1,000 followers.
I mean, if by next week there was 1,000 there, that would be absolutely amazing. I think that would make our day. So.
I must admit, when me and Andy created this, we never thought we would get to that anywhere near this time frame. We kind of estimated it'd be probably summer 21 that we would hit that, and the fact that we're potentially going to hit that in the next week at the current rate is just amazing testament to you guys in terms of what you've been doing for us and supporting us. So really big shout out to all of our eGP learners, and we will definitely catch you in the next episode.
Cool. So get out there, and we're not out there. Get in, stay inside, and enjoy your weekend. Okay. Take care, guys. Okay. Bye. Reaching for the end stream button right at the other side of my second monitor. There we go. It's gone. Okay. Good. And that felt like quite a nice episode. 30 minutes. I think that's okay. So yeah.